Today we're going to talk about E&M coding and why it's important to you. Evaluation and Management Coding, commonly known as E&M coding, is a medical coding process in support of medical billing. Practicing healthcare providers in the United States must use E&M coding to be reimbursed by Medicare and Medicaid programs, or private insurance for patient encounters. There are three things you need to know about E&M coding. First is the common terms used in E&M. Second, whether the patient is a new patient or established patient. And third, identifying the chief complaint and key components of an E&M visit. E&M covers visits you provide to your patients in many settings. Today we're going to focus specifically on ambulatory office visits. It's important to understand that clinical language is not the same as coding language. Your clinical visit will be translated into an alphanumeric code for billing and reimbursement. Why do we need these alphanumeric codes for each patient encounter? The codes represent what you did and why you did it. Insufficient documentation and coding can result in an inaccurate picture of the patient's clinical condition and can affect future patient care. Let's discuss new versus established patients. One of the first things you need to know is whether a patient is new or established to your practice. A new patient is one who has not been seen by you or a member of your group and same specialty within the past 3 years. For proper documentation of E&M services, a chief complaint is necessary for all visits. A concise statement of the symptom, illness or reasons for the patient's visit is required. If your clinical staff documents a reason for the visit when rooming the patient, the provider must revise or confirm that as a chief complaint. There are three main key components of an E&M visit: history, examination, and medical decision-making. History is comprised of three portions. First, history of present illness, or HPI. Second, review of systems, or ROS. Third, past, family, and social histories, or PFSH. HPI can be for an acute or new condition. Patients are describing their present illness in their own words. HPI can be described by elements such as location, severity, timing, and duration. In addition, quality, context, modifying factors and associated signs and symptoms are part of HPI. At follow-up visits, the HPI may be best documented by describing the current status of each of the chronic conditions. Diabetes, blood sugars have been within range, patient has been trying to follow diet. Hypertension, blood pressure has been well controlled. Hyperlipidemia, lipids within normal range. ROS, or review of systems, is an inventory of positive and negative symptoms the patient may have related to their chief complaint. If obtained by clinical staff, information must be reviewed and confirmed by the provider. Past, family, and social histories, or PFSH, includes a patient's past medical history, family medical history, and patient's social history, such as age-appropriate activities. If these are obtained by clinical staff, they must be reviewed and confirmed by the provider.